Welcome back, everybody. Mike Hislop for Orlando Medical Institute TV. We are going to get into bleeding and bleeding control. Hopefully less about bleeding and more about bleeding control. It's going to be a two-part series, so stay tuned. The fun is about to begin. Let's jump right in. Introduction, right? A before B, except after C. It comes down to got to take care of that airway, got to establish breathing, get oxygen on those red blood cells, and then it comes down to circulation, right? Without blood returning back to the heart, perfusion goes down, so it doesn't matter if you're breathing well if you have no blood, right? So massive hemorrhage is going to obviously be associated with really bad outcomes. And bleeding, you're time sensitive. Everything is about, if we can't stop the bleeding in short order, everything is moot after that, right? Everything else you did and or are trying to attempt is going to be quite useless. So the worst kind of bleeding, obviously, occult bleeding, right? Hidden bleeding, bleeding on the inside. External bleeding, no patients in front of us should ever have a bad outcome, because up to including the use of a tourniquet often and early, we're going to be able to stop that kind of stuff, right? We're going to be able to stop even an amputation, even the worst bleeding. Good tourniquet control is going to be able to stop that immediately. Airway management requires adequate circulation. You can't manage an airway effectively without circulation. You're just wasting time, essentially. You got to understand the A&P. You got to understand how your body's going to respond to bleeding, and how your cardiovascular systems and your respiratory system integrate to putting all those oxygen molecules on those red blood cells. Because if we're not moving around, you can't get perfusion. You don't get perfusion, you're going to become acidic, more coagulopathies, more hypothermia, i.e. you don't have good outcomes. Keeps blood flowing through the lungs and peripheral tissues, right? That's its job. Right side of the heart's going to supply blood to the lungs, pick up that oxygen. Left side's responsible for getting to the body. So it's got to be able to keep coming back. This is just a simple pump. Without blood supply coming into the pump, you can't expect blood supply out. So all bleeding eventually stops. We would prefer to stop it on our terms rather than the patient having just run out. Unloads waste, picks up oxygen, right? Basic lung 101, gas exchange at that alveolar space. And the opposite of that at the tissues, right? So we put oxygen on the red blood cell, it does its travel to the end organ user, drops it off, picks up CO2, ends up back to the lungs, and does the opposite, right? And both of those are required for a good mutual relationship, because there's no reason to put oxygen on a red blood cell that can't deliver it to the organ. No, don't even load the trucks if they can't get to where they're supposed to do deliveries. It's a moot point. So perfusion is necessary, that cycle of perfusion. If blood is stopped or slowed, obviously cells are going to start building up acids, potassium, cell walls are going to start to disrupt. Now you can't deliver oxygenation. You switch from aerobic to anaerobic, right, without oxygen delivery to those organs. And typically, profound acidosis is going to include. Remember back into that A&P in the Krebs cycle, you start building up that carbonic acid, carbolic acid, pyruvic acid, lactic acid. You can't get rid of that. You're going to go into cardiovascular collapse, and it's going to be the causality of death, the inability to make energy at the mitochondria. Repetitive pumping process, right? Preload, got to have supply to the pump. Without that, obviously, that's what's going to be negatively impeded upon bleeding. Not the fact that the blood's leaving, therefore it's not coming back to the pump. Less in, less out. Frank Starlin said, you don't stretch it, less force of contraction, less preload. Afterload, pressure in the aorta against which the left ventricle has to pump. So typically not diastolic pressure, right? So systolic versus diastolic, they're both arterial pressures during pump, during relaxation. Very often that's seen as being arterial and venous. That's just not the case at all. If in fact you get into blood pressure, and that's going to be a relative formula here, cardiac output, right? Times peripheral vascular resistance, what you're putting out. What was that cardiac output? Stroke volume, how much per beat, times heart rate equals cardiac output. Now cardiac output times what it has to push against, that's what's going to be giving our blood pressure. Many protocols, archaic ones if you will say minimum 100 systolic, minimum 90 systolic for medication administration or condition assessment. And really the new kid on the block is that mean arterial pressure. Much better picture of perfusion. So we have to know how to figure it out, right? Although many of our automated machines are going to give you that third number there, systolic, diastolic, and then hey, that third number, that's mean arterial pressure. It's diastolic pressure times 1/3 of pulse pressure, right? So, or pulse pressure, systolic minus diastolic. Either way, you get your mean arterial pressure. and it's typically a greater than 65, you're perfused, right? Under 65, you're in a hypodynamic or hyperperfused state. Amount of blood pumped through the circulatory in 1 minute, that's cardiac output. And we know that that's stroke volume, how much volume per beat of the heart, or heart rate. More venous return, more stretch, more cardiac contractility, better blood pressure. So obviously, conversely, less is less on both of those, and you're going to reduce perfusion. Normal heart pumps about the same percentage of blood that returns to the right atrium. You bring it in, it pumps it out. That's its job. It keeps a relatively status quo like that. It's all connected to, you can't get out what you don't put in, essentially. So maintain position changes, like if you stand up quickly and your heart rate goes up a little bit, to maintain an equilibrium and keep that cerebrum perfused so that you're not symptomatic. What's in blood? To understand the coagulopathic cycle and how we make clots and how we survive injuries and bleeding, and certainly in trauma, it comes down to understanding blood. So the liquid portion of blood, it's a yellow straw-colored stuff. It's just the liquid. It's the medium by which we move resources around. But the formed elements, that's the solid parts, right? Red blood cells, white blood cells, platelets, even fibrogen and some other materials that are within blood that help us with our clotting and certainly infection control, and as a transport mechanism for oxygen, certainly. Purpose of your erythrocytes or red blood cells, it's to carry oxygen from point A to point B, carry CO2 back, right? So nutrients and wastes, to get rid of those acids, to get rid of those metabolites, deliver stuff through the kidneys for excretion. All of this stuff happens based on the functionality of the distribution of blood. So if it can't get there, it can't do its job. And its job is absolutely in every way integral into you staying alive. So without good perfusion, without good blood flow, first an extremity dies, then an organ dies, then an organism dies, then you die, right? So, and you typically do it in that order. Plasma, again, that watery straw-colored portion, that liquid portion of blood. Platelets, these are small little tiny cells, chunks of basically resources of dead red blood cells, resourced, and they're designed for fibrogen to find themselves an opening or a disruption of the vesicle. Fibrogen, those strands of protein, get in there, and they create a construct, much like gauze, if you will, much like those boxes on gauze, that works the same way. And then clots get caught up in all that, and i.e. you've made a scab or a clot, whether it be intravascular or as a wound surveillance. Clotting proteins, plasma, other proteins, all the everything's going to work together in order to create a clot. Arteries always carry blood away from the heart. So even for those of you that will confuse the pulmonary versus pulmonary vein having the oxygenated and pulmonary artery having the deoxygenated, arteries always carried away. So as we talk about that right ventricle contracting, that pulmonary artery now takes it to the lungs to get oxygenated, because an artery always carries blood away from the heart. You'll likely see that as a question in the future, if not on boards, maybe multiple times. Veins automatically bring it back. So perfusion needs both. So if you cut a vein or you cut an artery, obviously you're on the clock as to reparation or you're going to run out, right? So autonomic nervous system is going to make adjustments to make that need. It's going to use those catecholamines, right, within flight or fright response. You're going to dump epi, peripherally vasoconstrict the tank into being smaller, if you will. If you're peripherally bleeding, epinephrine actually helps you pull blood away from that area and handle it, right? Increasing blood pressure, increasing force of contraction of the pump. Chronotropic, inotropic, dromotropic, all those things are going to be basically flight or fright. Whereas the parasympathetic, we know that's rest and digest, feed or breed, if you will, depending on your generational when you learned. Flight or flight typically is those catecholamines. That's about turning everything up. That's response to injury, insult, fear, all those bad things. Vasomotor control center, that's in the medulla oblongata. It helps regulate blood pressure. That's the base of the brainstem there, your primordial caveman brain, if you will. Endocrine system is also going to jump in. Because it turns out if you begin to bleed or you're low on volume for whatever reason, you're in hypovolemic shock. That doesn't necessarily mean hemorrhagic shock. That's just more specific, because certainly blood is volume. So hypovolemic shock is your body's going to respond by dumping aldosterone. It's going to dump antidiuretic hormone. Why? Because you need the fluid. So there's really no reason for your body to excrete any into the bladder for excretion. It's going to want to recirculate that. So you're going to dump that antidiuretic hormone at the times of catecholamine responses or flight or fright. Insufficient circulation, obviously hypoperfusion. Shock, right? End tissue hypoperfusion. End tissue meaning skin. So if you're looking at somebody pale, cool, diaphoretic, by definition they're in shock. But what's their heart rate? What's their blood pressure? I don't care. That patient's in shock. They have end tissue hypoperfusion. Delivery of oxygen. You got to have a pump. You got to have it the right rate. You got to have the right amount of vessels, that they have to be intact, and you have to have blood, right? So all of those things are required for these systems to work in place. Any disruption of any three of those, then obviously you're going to run a deficit. You're going to be in shock by definition. Hemorrhage, just another nice word for bleeding, right? External hemorrhage, easy, direct pressure, elevation, pressure point, tourniquet. Tourniquets more often and more early, right? So because obviously tourniquets in other generations meant life or limb, like you gave up an arm, you gave up an extremity to place a tourniquet. That's not the case anymore, right? These people are getting reperfused and limbs are saved, but what we want to do is, as I said earlier in another trauma assessment, save seconds and cells. So we're not going to give up any blood just to fail into a tourniquet. I would suggest, and certainly the trauma gurus would suggest, go with the tourniquet more early for something that's clearly arterial and not likely to be stopped by any other method. External, obviously the extent and severity, what are you going to do, right? Is it capillary bleeding? Well, that's just oozing, right? That's a basic dressing. Veins, or that oozing red blood, but not bright red and not spurting, then typically a good pressure dressing is going to stop venous bleeding. But if it's arterial bleeding, there's a really good chance you're going to have to fail into a tourniquet. I would suggest, again, earlier. Save those cells. We're going to restore blood flow afterwards with vascular surgery and get the patient fixed anyway. If the injury is large enough, a person can exsanguinate in just a few minutes. You hit a large femoral artery, large brachial artery, carotid artery. You're talking about 120 seconds for a carotid artery. You don't have a lot of time. Big arterial bleeding means no preload back to the heart. You're going to be in PEA and you're going to die. Hemorrhage can appear anywhere. Why? Because you're vascular everywhere. Non-traumatic bleeding, typically GI, right? And you think, well, so who's gonna be putting blood into the toilet, whether in urine or in stool, and not report it immediately? And what we find is people are absolutely unaware. If you have black stool, that's blood, right? You're dumping hemoglobin, you're processing it through your GI system. And over a long period of time, not even an acute big loss of blood, but over a long period of time, that absolutely can be insidious and cause significant problems in your patient. And they can get orthostatic and be quite pale and have these demonstrative change. Ruptured ectopics, horrific amounts of bleeding. Ruptured aneurysms along the aorta, whether it be thoracic, DeBakey 1, DeBakey 2, or those AAAs, right? The ascending aortic aneurysms or abdominal aneurysms. These are all obviously linked with a high mortality rate, because if you bust the largest arterial artery in your body, there's a real good chance you're not going to have great outcomes. So we have to surveil for the risk assessments and certainly the presentations of these patients. They have to be treated properly. Internal trauma, right? Internal bleeding. This is the one that's insidious, right? And it makes you kind of go against your realm a little bit, and you want to restore that 120/80 to everybody, and you want to keep everybody above 90. But sometimes it's the law of diminishing returns, and certainly with internal hemorrhage, that's certainly the case. They're going to be tachycardic. They look pale. They have pain. They have tenderness. Blood is toxic to those peritoneums, so you're going to be aware. And your patient's going to show you in a couple of ways. You just have to be able to filter and look at it through the right eyes, right? Body cannot tolerate more than 20% or 1/5 of their blood supply. Typically, if you get near a third, you're already in decompensated shock, 30%. So that's quite bad. Typically more than a liter. Remember, you go and donate blood, you donate 500 cc's. So more than that, and you're okay with like a cookie and orange juice and you're back to good. So compensation depends on how rapid a person bleeds. Did it leave quite quickly, or did it leave over a longer period of time? In which case, a longer period of time, you actually compensate better. But quick, large amounts of blood loss, typically you don't compensate quite as effectively, I'm afraid. Consider bleeding serious, right? If the mechanism's good and your patient's tachycardic and hypotensive, they're bleeding. If it's not on the ground, it's in their gut. And math is always going to back you up on that, right? So if it's not in their guts, it's in their chest, in which case it's not going to change much on your prognosis. They need trauma surgeon and blood, and they need it now. Significant amount of blood loss, obviously, whether it be rapid, you got to control the bleeding. External, nice, immediate control of external bleeding is necessary, especially when we have an arterial bleed presentation, certainly. If it's bright red and it spurts and it's difficult to control, just recognize that, hey, that's fire engine red, it's arterial, let's stop this immediately and make it a priority. If it's oozing, it's flowing steadily, but in truth, it's dark and it's under much lower pressure, and it's likely a good pressure dressing is going to take care of that. And it's likely you're not going to need a tourniquet to take care of that kind of bleeding. And obviously the capillary, or that slow oozing, is again, that much slower. And even a good surface dressing is likely going to take care of that. Venous capillary, more likely to bleed, clot than arterial bleeding, simply because if you cut two pipes, and they're both 100 years old, the one that's been trickling blood through it has gunk in it, and the one that's been under high pressure a long time, it's really hard to stop those, right? So they don't tend to clot nearly as well, and it's going to take time. Bleeding tends to stop within 10 minutes, venous capillary bleed. They're going to clot on their own, right? It's because it's low pressure. Because they're designed. There's that fibrogen that's locking up those red blood cells, and it's using those platelets, and it's going to stop. And first fill it. You're going to get your platelets get aggregated and your fibrin formation and all that vasoconstriction, reducing pressure in that particular area. All these things are going to work together to hemostasis, right? To stop blood, right? Stop bleeding. And typically it's quite effective. Under high pressure vessels, obviously that's much less likely to be effective as a source, because you're just throwing those clots out even when you start to form them, and it typically doesn't work out well. Hemophilia. So these clotting mechanisms, these things that enact platelets or enact fibrogen in the clotting cascade made in the liver, if you're deficient in one of those, you have some form of hemophilia. You're missing one of said to be your factors, right? And obviously, any bleeding for these folks is considered significant, right? They can bleed to death from a nosebleed. Even atraumatic bleeding is quite bad. So we have to know a little bit about a patient's history and certainly understand that if we are unable to reverse the things that we know lead to death a great deal, we're not likely to be successful. And that specific triad of death, right? If you're cold, if you're coagulopathic, whether it be because of a disease process or because you're cold or acidic and you become acidic, typically those three things now feed on each other and lead to bad outcomes. So those are the three things we want to avoid first and foremost. Acid, it's about getting them perfusion. You don't build that acid. Coagulopathies, again, related back to being cold. That changes your patterns. So things that we can adjust, can manipulate, and can control, we must, because there's so much that we can't control. So we have to obviously be hyper-aggressive on the things that we can. Keep them warm, right? Proactively keep them warm. Not just covered, but actually in a warm source. Shock, respiratory failure, pump failure, poor vessel function, if you have a significant amount of bleeding, internal or external, all of these things are going to rely and leave your patient in shock. Hemorrhagic, obviously in trauma, by far the most common shock. Respiratory failure is going to be right behind that because of, again, that profound acidosis. Acute allergic reactions are anaphylaxis, closing off, bronchoconstriction, vasodilation typically, or overwhelming infection in the sense of sepsis, right? Septic shock probably kills more patients than all the other shocks combined, I would suggest, just based on that infection getting into your blood. Hypovolemic shock, again, it's volume. That's very generic. When we talk about blood, it's hemorrhagic shock. It's just a little more specific, but it still falls under hypovolemic. You're losing electrolytes. You're losing the liquid portion of blood. You're losing the formed elements. You're losing whole blood. In which case, first and foremost, let's plug the hole. That's that trauma surgeon. And then we can fill it up with blood. That's the trauma surgeon with a guy with blood standing right behind him. So we know where that happens. They happen at trauma centers, and typically that's what's going to be necessary. Blunt or penetrating trauma, long bones, again, their bone marrow is vascular, right? You're going to lose some blood there. Vascular injuries, obviously great vessel tears or even peripheral bleeding, multi-system injury, all of these things are going to put you at potential risk for traumatic shock or hemorrhagic shock at that point. Obviously, there are things that can make you bleed significantly to death that are medical in origin, right? Your ectopics, your AAAs, your abdominal aortic aneurysms, all of which can do that. If you hit the heart, you can bleed. If you hit the liver and spleen, we know they're highly vascular. These can certainly lead to exsanguinations, even in short order, right? They're quite quick. Hypovolemic shock caused by hemorrhagic trauma, classified again into 4. Class 1 and 2, these are your compensated shocks. You're going to be tachycardic in 1 and more so in level 2, but the big delineation there is you have not significantly dropped your blood pressure. you have not decompensated yet. Once you drop your blood pressure, you're now in class 3 shock or decompensated shock. Class 4 is irreversible. So if we wait for the blood pressure to drop in class 3, we're very close to irreversible shock. We have to recognize shock when it's in class 1, class 2 to get hyperaggressive, not to allow them to fail into decompensation. That's what's going to have our best outcomes for our patients. This is going to, a little graph on table 30-2 that just basically delineates how much blood loss is usually associated with each type of shock and what percentage. So typically, as I said earlier, about 30% of your blood, or a third, right, about 30%. That's where you're going to lose in order to lose your blood pressure through hemorrhage, right? And typically you're going to have a thready pulse. You're going to be hypoperfused. 1 and 2, compensated shock. 3, decompensated. 4, irreversible. And we have to understand what's going to be necessary in all of these progressions, and understand that it's going to change in both presentations. Whether this is blood we could stop, or bleeding we cannot stop, because we have to treat those two patients quite differently. Even though perfusion is the priority on both of them, one's cure is the other one's death sentence. So we have to be quite clear as to what we have. Initial stage, obviously categorize it, right? What do you have? Are we early? Are we mid? Or are we late? Or are we even like if we're significantly hypotensive, tachycardic, pale, cool, diaphoretic, you're in stage 3, potentially stage 4 shock. This is quite bad, right? We hope to get aggressive and get ahead of that before these patients has to digress into that kind of presentation, because their outcomes get worse and worse and worse. There's a reason they call it irreversible shock. Compensated versus decompensated. The big delineation, blood pressure, right? I'm compensating for my injury, my insult. I'm compensating with heart rate, peripheral vasoconstriction, all these catecholamines in order to continue to get the job done. That's compensating. When you no longer are getting the job of the circulatory system done, that's decompensating. That's stage 3 shock. It's the first time you have a pretty median to significant drop in blood pressure at that point. And mental status is right behind that, right? Stage 3 and stage 4 shock are associated with hypoperfusion to the brain. You're going to not talk to us anymore. You're not conversational anymore. And that's that big indicator that even in patients with hidden bleeding here, once you get altered and you're losing consciousness, we have to give you fluid. Even though we know it's not the fluid you need blood. But we'd like to plug the hole before you even get the blood, but sometimes you have to do what you have to do in those instances. But unfortunately, we know the prognosis in those patients are pretty poor. I don't want to give somebody 2 liters of fluid that's bleeding in their belly and put more blood loss on the table, right? It's actually counterproductive. There are times where you have to make those tough calls, but you should hate the concept and you should delay it as much as humanly possible, especially for a patient. If they're mentating, the brain is very sensitive to pressure. So if they're mentating, don't do it. Just hold off. All right, so this has been Chapter 30, Part 1, Bleeding. Return for Part 2 soon.